Thank you so much for being here today. It's a lovely afternoon. My name is Amber Taylor. I am the Communications Director for the American Civil Liberties Union of the District of Columbia. We are here today with the DC Crisis Response Coalition for a very important matter to make sure that people in the district, when they're experiencing mental health crisis, get the care that they deserve. The district is not doing what they need to do in order to take care of our residents, our neighbors, our family members, our friends. And it is our job, our responsibility to make sure that we are empowering the district to invest in the services and expertise that we need to take care of our families, our friends, our neighbors. Today I'm going to introduce three lovely speakers who are going to talk about both our policy platform and share some personal experiences that they have had when it comes to our current crisis response system. And again, what do we need to do to change and what we're asking the council and the mayor to do. We are also going to ask that reporters hold questions until the very end of this presentation, and then we'll happy to take any questions that you have. We'll be live streaming the event on Twitter, so you can also find that there. And with that, I would like to introduce our first speaker, Michael Perloff, who is a staff attorney here at the ACLU, the District of Columbia.
If I had a heart attack right now, I would want someone to call a doctor, not a doctor. And I think for all of us, if our spouse had an asthma attack in the middle of the night, if our son broke their leg, we would call 911 and want to have a trained medic, not another government employee, respond. But that's not what happens with mental illness. That's not what happens with mental illness in the District of Columbia. When you call 911 in the District of Columbia, the most likely outcome if you're calling about a mental health crisis is that you're going to get a police officer. In fiscal year 2022, there were over 36,000 calls that DC 911 operators routed to police officers involving mental health. DC's 911 operators routed only 327 mental health calls to mental health professionals. No one wants this. Not people with mental health illnesses. The advocacy organizations that serve those individuals, they consistently say that mental health professionals and not police officers should be the primary first responders for mental health crises. The majority of Americans don't want it either. In a recent survey, 84% of Americans said that they want mental health professionals, not police, to respond to mental health crises. And we think that police officers don't want to be doing this either. They went into police work. They didn't become social workers. But mental health emergencies have become just another social challenge that are dumped on law enforcement's desk. This system that we have, it's not working. More than 50% of black men with disabilities nationwide will be arrested before they turn 28. Let me say that again. More than 50% of black men with disabilities nationwide will be arrested before turning 28, double the rate of their white peers. Here in the district, we've heard about police officers responding to mental health crises by slamming the person in crisis against the floor or against a wall, by making needless arrests, or just scaring the person so badly that they ran away without receiving any care. We as a community can do better. And that starts with adopting the framework that the federal agency responsible for mental health policy, the Substance Abuse and Mental Health Services Administration, adopting the framework that SAMHSA organization says every locality should adopt. It has three parts. First, someone to talk to, trained mental health specialists who can triage emergencies and make sure that when a call can't be handled telephonically, the right people come to the scene. In DC, we have crisis call centers, but we don't have crisis call centers that enough people know about, that provide sufficient services, And we don't have 911 dispatchers that dispatch enough calls to those centers. With new protocols, more services, and more investments, we can turn the call centers we have into the ones that we need. The second part of this program is someone to respond. Non-police responders who are capable of responding to mental health crises, mental health specialists who have the training and experience to provide people in crises with the care they deserve. Again, DC has professionals who provide some of these services, but not enough. A call to those individuals will take hours, all the while the person in crisis has their trauma grow and grow. And finally, the district needs a place to go, not just the hospital, because psychiatric emergency rooms are traumatic places, loud, dark, places that have long waits, places that practitioners tell us can make a crisis worse, not better. So we need community-based facilities that federal agency, SAMHSA, they say are most appropriate for resolving most crises. 10 years from now, we may look back at these types of reforms and not be able to imagine a time we didn't have them. It wasn't until the 1960s that we had ambulances to address physical health emergencies. Before then, if you had a heart attack, an asthma attack, a broken leg, you had to call a funeral parlor and hope that a hearse would get there in time to take you to get medical assistance. An ominous start. We in DC can do the same thing that was done for physical health emergencies, for mental health emergencies. We can do it and we must do it, because the 129,000 DC residents who have mental health illnesses, our brothers and sisters, our community members, our teachers, our lawyers, our business owners, our peers, they deserve more than what they're getting right now. So what I want to do is introduce Charnel Chaney, the founder of Bold Yoga, who's going to talk about her lived experience with the district's crisis system. Charnel?
Thank you. Good morning. My name is Charnel Chaney, founder of Bold Yoga. A few years ago, I was in a domestic violence relationship. And one evening, me and my abuser got into a fight that led to me being choked until I was passed out. Moments later, me being awakened, the police was knocking at the door, and they had said that someone had reported that there was violence in the home. They can clearly see that the house was in a disarray, so something had happened. But due to the relationship between the Black community and the police, I wouldn't tell them what he did. But the police have broken their trust with the Black community over and over again, because when they show up, they don't de-escalate the situation, they escalate situations. They became angry at the fact that I wouldn't tell them what was going on. I just kept asking them to just please make him leave. They wouldn't make him leave. So I told them, if you don't make him leave, then I'm gonna wind up jumping out the window. They said, oh, well, now we're gonna take you to CPAP. I said that so they could understand the severity of the situation of me wanting him to leave. My anxiety, CPAP is a mental hospital where they take mental patients. All I've ever heard was bad things about these places, so immediately my anxiety started to go off and I went into a panic attack. I started to cry. They grabbed me by my arms and my legs and dragged me all the way to the car, yelling and screaming, having a panic attack, and threw me in the back of the car, drove me to United Medical, where they dropped me off. United Medical sedated me. I woke up, I wound up leaving. Fast forward, I sat on a panel with police officers and medical professionals, and I told this same testimony. The medical professional was able to bring everything full circle. Being that I was choked until I was passed out, there was no circulation going to my brain for me, so I should have never been questioned in that moment. The abuser should have been removed from the home immediately, and I should have never been questioned in front of him. I'm sharing this today as evidence to say that the police are not equipped or trained to handle domestic violence or mental health situations. We need mental health professionals that can show up and can de-escalate the situation rather than escalate the situation. Thank you for allowing me to share my testimony. Next, I want to call up Chioma Oru, representing the Akuma Project. Thank you.
Thank you. Good afternoon. Again, my name is Chioma Oru. I am the mother of Atulegu and Jidofor. Atulegu, or we call him Ati, is an artist. He loves to draw. He's very creative. Since the 18 months old, he's been drawing almost exceptionally well. He's autistic. He doesn't speak. And he sometimes has meltdowns. Jidofor is also autistic. Jidofor is a sweet boy. Jidofor loves hugs and kisses and will offer them to anyone he trusts or feels can receive them from him. Jidofor has a sensory processing disorder along with his autism and sometimes has problems with things and has meltdowns himself. I'm also the sister of Izenwa. Izenwa Oru is my brother, or should I say was my brother. Izenwa died last year, almost a year to the date. Izenwa is a creative spirit, the most loving brother, the most loving uncle, my step-in, no one has my back more, creative spirit and soul, a real Renaissance man. But Izenwa was also schizophrenic. And Izenwa had meltdowns in his own nature, and sometimes would be dysregulated and disoriented to the point in which my family and myself, depending on who was with him, on occasion would have to call the police for him. We could only call the police because we had no other option. We'd call 911, we'd tell them he has pre-existing mental health conditions and we need help. Of course, when the police comes on site, oftentimes, whether it's for my brother or the children that I birthed or other children in the community that we support that go through these crises, the last thing on the mind of a first responder is that they're brilliant, that they're loved, that they have gifts, that they offer things to the community, that the problem is not their family or their condition, but it's about how the system responds to them and their condition and their loved ones who only seek and want help. That is part of my story. That's part of what drives me. I believe the system failed Izenwa. Izenwa in his last years was really on a path of recovery, but he lost his own battle with life, of which I know had we had working systems, not just crisis intervention, but preventative and early intervention care, appropriate support and services for people with disabilities, behavioral health conditions of a wide range that manifests in different ways. If we're supported and treated as human beings that have things to contribute, we would not, Izenwa would not be dead. And prayerfully, my children, and part of what drives me in the work that we do, part of what we're doing with the Akuma Project team, we're a team of caregivers, family caregivers like myself, mothers, sisters, daughters, aunties, cousins, those of us that are directly impacted. We have been looking at the impact on our children and our youth in terms of the mental health services, and DC is promoting a school-based mental health service program that does not also have a vision for decarceration, decolonialism, and things that promote our dignity and respect as people with disabilities that have the rights to be disabled. That we have a right to be disabled in a way that has nothing to do with the police. We deserve not just a clinical workforce that can support us when we need it, we also need a workforce of peers, people who humanize our condition, people who see us, respect us, know us, and actually care about us. So we stand here for the children specifically, but Izenwa was not a child. Izenwa was 47 years old. He died too young. He was a Washingtonian, went to Benjamin Banneker Academic High School, went to George Washington University, and he is not here making his contributions because the systems of care have failed him. He did not receive appropriate crisis care, and we stand behind this bill or this motion to really increase awareness of what we need to have appropriate crisis care intervention that recognizes the whole human beings that go through these systems, and we do so recognizing that our children, particularly who have a range of behavioral health needs, deserve this level of thought in our policy and implementation of services. Thank you.
What do we want? Safety for all. When do we want it? Now. What do we want? Safety for all. When do we want it? Now. What do we want? Safety for all. When do we want it? Now. What do we want? Safety for all. When do we want it? Now. Thank you so much. At this time, we'll take any questions that reporters may have.
So we
Yes,
heard
sir?
about her brother. What happened to him? You didn't tell us what happened to him.
My brother died, right, in April last year. As I mentioned, he has been through systems of care in DC, in Maryland, in Georgia, in California. I mean, we've been all around this country supporting my brother. He developed a substance use disorder along the way to self-medicate and manage his care, which led him down a path of diabetes. He worked till the day he died, but he just did not. He never was able to qualify for Social Security. He never was able to get the appropriate support and services ever throughout his life. He had his first breakdown at 23 years old, and by 47, he's dead. He died of, I would call it alcoholism, but I consider it suicide and complications from diabetes. But this is all from never having appropriate treatment. He was in and out of hospitals, and because he was over 18 when he had his first breakdown, we were never really able to as a family be respected as his supporters. So at the end of the day, the way that I see the crisis intervention has failed Izenwa and failed many. I mean, I can go down the line of him and other family members and other people that we love, is that he would go in, be brought in by the police, sometimes be escorted by crisis or clinical specialists, be taken into the ward. He would be kept there, medicated temporarily, and then discharged within 3 or 4 days back out to the street to figure it out by himself. We went through years of this cycle, decades of this cycle, and Izenwa just did not win his battle, and we could not help him because we did not have the support to give him what he needed.
When you would call the police, what would happen? You said sometimes the police would come, sometimes mental health workers would come?
Yeah. So sometimes when the police would accompany, I remember distinctively, we grew up in Ward 4. This is after I come back from college, and Izenwa was in his 30s at this point. Izenwa, one time I had to call the police myself. Now that's a very hard thing for me to admit, considering I am an abolitionist, but we had no choice. I called the police. This was in August in 2004. And Izenwa was violent towards my brother and him. We were trying to get him to go get his injection. He gets these injections for his condition, of which has negative symptoms, can cause you to be to not have a sexual drive, to lose your sense of life. And so he was resistant to treatment in ways that there were no options to explore what could actually work for him. And on this occasion, we just wanted him to take his medicine, and he just had a major meltdown. I'm the one who called the cops. The cops come on site. There was no mental health professional on site that day. And this was, again, a few, decades ago. And Izenwa, when the cops came, they started mocking him because he self-talks. He talks to himself when he's having a meltdown. He's saying, I don't want any problems. He's afraid of the police because that seems to be the only response that he felt would consequentially disrupt his liberty, which is why he didn't want to take the meds in the first place. They talked so badly about Izenwa. And then when I'm telling them to talk to him with respect, they're telling me, well, you guys should keep your problems to yourself if you don't want us to be involved. I will never forget that. I was not a mother at the time. It stays deeply in my psyche and in my mentality. And now as a mother who has gone through independent situations with my own children, you know, protecting my own mother's child, my brother, I see it now like manifesting even with my own children. RCDOT, this protest back here, called the cops on my 7-year-old for not wearing a mask. And luckily the police was friendly at that time. But again, there is the problem of the police, and then there's the options of having no one else to call, whether you get officer friendly or not. I've seen it happen to Izenwa. That was one example. We have so many. You would have to get into, like, you know, I could write a whole book on how many different incidents we have faced as a family. And I say that as a family because it didn't just impact him, it impacts every single one of us. It impacted my decision making in terms of where I would work and how I would work, because I'm a caregiver, and you disrupt one's ability to support their family if the systems of care don't work. And I think I've taken up enough space on this.
Any other questions?
What about the idea of police working in tandem with caregivers? I guess your information talking about cahoots or something like that from Eugene, Oregon. Did they do that in D.C.? Are you advocating for that?
So first, talking about Cahoots. Cahoots responds to the vast majority of calls they take without any police. And I think that has to be the starting point for the district, because most mental health calls just don't need police. And in fact, police will make the situation worse. What we've heard from practitioners, from mental health professionals, from direct service providers, is that seeing an armed police officer respond to you during a crisis physically changes the response to the person in crisis. They become more agitated, more scared, and as I said before, sometimes just run away. So the first priority for the district needs to be having as many calls as possible responded exclusively by mental health professionals. That's what other communities are trying to do, and that's what we can do if we devote the resources and energy necessary toward achieving that goal.
And what if those mental health professionals are afraid?
Well, I think what I hear in that question is an idea that a lot of these calls are dangerous. And I want to be very clear that there's a stereotype linking mental health calls with violence and with danger. But that stereotype really is just not correct. People with mental illness only account for 3 to 5% of all violent crimes nationwide. And in the district, research by the Department of Behavioral Health found that of the reported mental health crises to which DC's best and most trained officers responded to over the past 4 years, less than 1% involved a firearm. So most of these calls are not dangerous, and that's why many communities around the country are able to respond with mental health providers. We're hearing from clinicians who are saying, we want a mental health person to be present. We would call for mental health support, but the reason why we aren't able to do that, why we go to the police, is because it just takes too long. It takes too long to get someone there. So the problem in many of these situations isn't one of fear, it's one of resources. The will is there, the resources are not.
Any other questions at this time? Well, thank you so much for joining us today. We're going to head into the possibility now and make our demands known on the council. If there's any residual questions you want to ask us, we'll couple us will hang around for any one